So we're going to start out with head CT imaging by Dr. Gupta. This is going to be really good.
Thank you, Diane. Should I be speaking to this or this? Okay. So first of all, I think an apology is due. I know it's after lunch, it's beautiful out, and I have to drag you back into this dark room. But this will give you a glimpse of my everyday life. So now you can sympathize with me a little bit. So for next half hour, I'll be talking about some strategies that we use in head CT. Actually, I'm going to be giving two talks. The first talk is about actual principles of dose reduction, and the second talk is about image review. So let's launch straight into it. Strategy number one, make sure that each scan is justified. And I know it is sort of commonsensical. Even the lowest dose scan is wasted dose if it is not performed appropriately. And the onus of this, at least in a tertiary care hospital, falls on the fellows and the residents who protocol these studies. So they'll read the indication and they'll go through next day's list and call up physicians if they think an exam is inappropriate. And there have been some data saying as much as like 1/3 of CT scans are unnecessary. And I like this article from this esteemed journal here, where right next to beauty and aging and diet and health, they're talking about CT scans, okay, overexposed. And then I looked at the picture, and it's an MRI scan. It's a sagittal T1 weighted MR scan with different color codes. But then I said, no, they're making a very subtle point here. They're saying instead of doing a CT, when appropriate, do an MR scan. So that's the point being made here. So in order to sort of alleviate some of this onus on the residents and fellows for doing the scans, we at MGH have and also at Brigham have a system called radiology order entry system that has been shown to decrease the dose tremendously on a sort of per capita basis. It alleviates and eliminates some of the examinations. So you can log into the system, you can prescribe what modality you're going to use, what body part you're going to be scanning, and let's say you're going to do a head CT, so you'll select head CT. You can select whether you want the scan to be with contrast or without contrast, or you want that decision to be left to the radiologist who's going to protocol this scan. And then there's a very exhaustive list of all the symptoms that you can come across. Okay, I'm only showing you page 1 of this like 5-10 page long list, and then you can, for example, in this case, we have checked head injury, mild to moderate, with no neurological deficit. Now, based on this, the system will immediately tell you, well, there were 4 scans that were done previously. You can look at the report of those scans, and maybe after reading those CT scan reports, you can decide, well, this scan is not warranted. Maybe a head CT was done last week, and we don't need to repeat it. So far, it only goes within the system, so it has no way of knowing if the patient got a scan somewhere else in the world. But within the system, at least, it is making that check. And after that, it'll give you an evidence-based appropriateness criteria for that particular scan. So I know some of you are thinking, well, there are always clinicians who just keep checking boxes till they get the scan they want. And that happens. But most of the people actually pay attention to this. And so in this particular case, because there was moderate head trauma, it's quite appropriate. The appropriateness level is 9. And you can go ahead and you can select a site and schedule this exam. Okay. And by now this has been quite popular. There's been a lot of press on this one paper that came out, which showed that after the system went into effect, the trajectory of growth has actually leveled off, and it has made a difference in the overall utilization of CT. And I think this has been a great contribution to the overall population level dose reduction, if you will. Okay. So when appropriate, and if you have access to one, use an evidence-based, practice guidelines-based system, and that'll help a lot in terms of reducing the dose. The second strategy is to acquire each scan with care and love. Okay, sounds zenny. Okay, care and love. Okay, and I actually mean it, because I've seen technologists at work, and there are those who will like throw the patient on the table, okay, push some buttons, and the scan is done. And there are those who will like talk to the patient and really make sure that they are really doing the job well, and that makes a difference. So I went into our record, and here is a patient who came in, and these are not all the scans. There are probably like maybe 11 scans that were done in a period of about 3 weeks. Okay, the patient came in somewhere around here, and then sort of this is not in temporal order. Okay, but there are a bunch of scans that were done. There is 100% difference in the dose here, from the lowest dose scan to the highest dose scan. There are 3 different vendor types represented in this data set. There are 4 different types of scanners: portable scanners, PET-CT scanners, MD-CT scanners, and so on, 16 slice, 64 slice, and so on. Now I ask you, and I've done this test with radiologists in our practice, which is the highest dose scan and which is the lowest dose scan? And so they look at it and say, oh, there's more speckle in this one, and there is more noise in the other one. But if you look at the scans individually, what is offensive about some of them has really nothing to do with the speckle in the image. Okay, the quantum model is not what is more offensive than things like this. There's some leads there which are shadowing over here. Okay, the head is not straight in all of them. Okay, all these other parameters matter to some extent a lot more than the CTDI wall that was used. I mean, that definitely does matter. Gray-white differentiation is based on that. But all these other extrinsic parameters, they come into play. In fact, these are some of the doses, and you'll find there's only a weak correlation between the image quality and the actual dose that was used. So I would go out on a limb and make a statement saying technology matters. All the nice things that the vendors do matters, but the human in the loop matters the most. Okay? Because it's the care they show in acquiring a scan is what makes the scan. So moving on, these are the technologists' responsibilities. So they are responsible for patient positioning, centering, removing all the extraneous hardware, patient instruction, stop breathing, IV access, monitoring the IV access, delimiting the scout, making sure that the scout was performed at a low dose, even though it represents a very small portion of the overall dose. Picking out an appropriate protocol, not doing a temporal bone CT when a brain CT was prescribed or a sinus CT was prescribed. Okay, making sure that the field of view is right, scan range is right, and the parameters are appropriate. And then making sure that all the reconstructions are done appropriately. They are responsible for something like this, where by appropriately tilting the gantry or tilting the head, you can avoid the lens of the eye when appropriate. In trauma protocol, you may or may not want to do that because there can be trauma to the globe. And then you can reduce the dose to the, I have some more slides that will show you that you can reduce the dose to the lens by 87% by this simple maneuver. Okay. Centering of the patient is very important. I think this was alluded to earlier. Maybe there's another talk that will also talk about it. And there was a paper by Tom Toth back in 2006 that showed that when you off-center the anatomy, when it is not at the isocenter of the gantry, you can have a 22% increase in the dose if you are 4 centimeters off, and 30 centimeters if you are 6 centimeters off. Okay, all he did was took a water phantom and he elevated it and actually measured the dose. And that's because you are no longer in the sweet spot of your bow tie filter. Okay, and then obviously you're not applying the right corrections because of that. So good centering means good automatic exposure control and image quality. Technologists are responsible for tailoring each scout, making sure that the scout is performed at low dose and is targeted. As I already said, they are responsible for scan series, and scan length. Okay. There are some other more subtle points about scan protocols that should be kept in mind. One is about beam collimation. Okay. It is sort of traditionally said that the smaller beam collimation is better. Okay. And perhaps it is true in terms of some of the image noise that creeps into your slices. You will have less scatter if you're scanning only 2 centimeters of anatomy than if you're scanning 4 centimeters of anatomy. You will have better slice sensitivity profile because the cone beam artifact would be lower. But at the same time, you'll be performing more rotations. Okay, so it might take longer to acquire the scan. And there is a dose penalty, as was shown in the morning by a very nice illustration where there was almost a doubling of dose when you went from a 16, I forget the numbers, 4 slice to 64 slice or something like that. But and that's because of the penumbra effect. Every time you scan a certain piece of anatomy, you are over beaming because the anatomy has to fit completely within the sweet spot of your X-ray beam. The rotation speed, if you have a choice, you want to pick a faster rotation speed because that will minimize the overall length of the scan. And you want to pick the right kernels. And there's a lot of debate that goes on as to what are the right kernels to recon and push to the PACS. Okay? And typically you want a nice soft tissue kernel, which will show good gray-white differentiation. And you want a sharp kernel to look for the fractures and the other parts of the bony anatomy. There have been lots of talk about tube current optimization and tube current modulation. So I will not go back into the principles of this. I'll sort of mention this, the fact that the lowest amount of tube current that you can tolerate is based on the degree of intrinsic tissue contrast. How much, what is the intrinsic contrast in the anatomy that is under consideration. So if you're only interested in bones, for example, in a sinus CT, you can go for a very low dose scan because bones have high intrinsic contrast. If you're looking for gray-white differentiation, you'll have to increase the dose level. Okay, acceptable level of image noise, again, the same example applies. But these things are nonlinear. So if you double the dose, then your image noise is only going down by a factor of square root of 2. Okay, so there is that nonlinearity that you can use. So back in 2004, in our department, we did this simple experiment. For all follow-up scans, we reduced the dose by 50%. Okay, so this is performed at 170 MA. This was then being done at 90 MA, approximately 50%. Okay, so the dose was reduced by a factor of 2. What we found was, and it's obvious, that the Hounsfield units were not changed. The gray-white conspicuity was about the same, but there's a lot more speckle in this noise. Okay, and there was a 22% decrease in the overall CNR contrast to noise ratio. Okay, but for most part, for follow-up scans, this was actually deemed a tolerable image quality. And I'll show you some actual data. We have really come way down on our dose, and I was happy to have to see that at UCLA they have those levels which are sort of comparable to what we are doing, and so we are not out on the limb pushing the low end of the dose here. So adaptive tube current varies MA both in the radial direction and in axial direction. Both of them are important. We should dispel the coconut model of the brain, which is brain is a soft tissue surrounded by uniformly thick rind around it. The thickness of the skull changes. In the front, there is a lot more skull than in the sides and in the squamosal portion of the temporal bone. It's actually very thin. And that's why a blow to the side of the head is a lot more dangerous than from the front of the head. So radial change in your MA is important. Also, the axial direction, so as you go along the Z direction, that is also important because when you go from, let's say, the apex to the skull base, there is a very significant difference within the brain when you hit the sphenoid bone. And you have more of this effect when you're doing head and neck together, because the moment you go from neck to the shoulders, there's a very large difference in the overall attenuation, and your scanner has to be able to account for that. There are other considerations. Lower the KV value when appropriate, for example, in pediatric cases. There are these newer scanners that advertise automatic KV. It's only automatic KV selection. It's not KV modulation, as was pointed out in the morning. And that's an important point, because I don't think KV modulation will really work, because you're changing the beam energy as you're going around the patient. So you can only pick one value, a lower value, and then you can acquire your scan. If you're looking for contrast-enhanced structures, for example, in a CTA or in a perfusion scan, you can really lower the KV value. In most perfusions, really scans should be performed at 80 kV. Okay, avoid scanning the same region. So if you're interested in temporal bones, you can do a head CT, and you can extract the temporal bone out of that head CT, especially if you're doing a helical scan. Similarly, same thing for the sinuses, same thing for the facial CT. There's no point in repeating the scan. By the way, when you do that, you cannot bill for 2 exams, and that's a billing fraud. so that should be kept in mind. And maximize image quality parameters. Again, remove extraneous hardwares, optimize contrast bolus, and angle the gantry through the clips. So there have been some papers. So if you're looking at aneurysm clips, you can tilt the gantry in order to avoid all the artifacts falling in one slice. Okay, very few people do that, but if that's your clinical question, is there a neck to this aneurysm, you may want to do that. There's this other aspect of whether to do helical scan or axial scan. And there have been papers about it, and there are lots of debates about it. Okay, I have sort of a mixed feeling. I have a preference and I have a bias, but I cannot strongly advocate one or the other. Okay, it's a personal decision to some extent. Okay, so the conventional wisdom is axial scans are better in image quality, and they are lower in dose, but you cannot do coronal and sagittal recons, and you cannot get thin slices retrospectively at an arbitrary slice. Okay, in my mind, the question boils down to how averse are you to exposing the lens, and how tolerant are you to the artifacts, and how much you love sagittal and coronal recons. Okay, it's a judgment question. So let's look at the image quality first. Okay, this was sort of always believed that axial quality is better than helical quality. Okay, in my opinion, actually, that's not always true. And there have been papers about it. So there's this paper by Stratton back in 2007 that showed that if you acquire thin slice helical scans, which have all these artifacts coming from the windmill artifacts from the helical motion, and then you averaged a few of them together, as was done here, you can get rid of most of these artifacts. Okay, there'll still be, the helical scanning will always have some penalty in terms of these types of artifacts, but you can substantially get rid of them. The other thing is about the lens dose. Okay, so there's this paper by Tan et al. In 2008 where they're showing you, so these bars are 16 slice and these dark bars are 64 slice. So the first 2 scans are with CT brain in a tilted axial mode and with the care dose on in the second column. And clearly when you tilt the head so that the lens is out, the dose falls considerably over a helical scan where you cannot tilt the gantry. Okay, sorry, not tilt the head. You can always tilt the head. You cannot tilt the gantry in a helical mode. So obviously the dose is much lower when the gantry is tilted and the lens is out of the field. The other take-home point here is that MA modulation matters. So when you go from here to here, there's a dose. This is with the dose modulation off, and this is with the on, and you can reduce the dose. Same thing over here. When the tube current modulation is off, and when you turn it on, the dose comes down on both 16 and 64 slice scanners. And the third thing that also is shown here is that 64 slice scanners do better than 16 slice scanners. Okay, all these are sort of obvious points that have been made before. Okay, but the main point here is the lens dose is affected by the way you scan. Okay, so axial versus helical. My bottom line is at MGH we do helical because we like our coronal and sagittal recons. Okay, And we don't really find that much image quality difference. Also, our doses are actually pretty good. This is a slightly older number, but you can bring the dose down with that. There are some artifacts, but we can read through those artifacts. And the main disadvantage of gantry tilt is eye dose, but many times that is acceptable only because we are doing scans for trauma or things where eyes have to be examined. Okay, so I got to go a little bit faster here. So adapt scan protocols to the clinical situation and indication. Okay, so you can tailor the protocol. So if you're looking for basically sinus CT for functional endoscopic sinus surgery, you can really reduce the MA to a very small value. The same thing with pituitary CT. Before every pituitary resection, we do this Varangian protocol where it's thin slices, it is tailored so that it can be loaded into the stealth station so the surgeon has a guidance to where the bony anatomy is. Very low MA is appropriate. And it is good to have several different types of protocols appropriate for the clinical indication. And when you can when you have some history given, you may be able to pick an appropriate exam and lower the dose. So for example, here is a pediatric scan for craniosynostosis done between like 0.04 to 0.08 millisieverts. Again, a perfectly readable bony anatomy. Okay. Another pediatric scan done at 22 milligray CTDI. Again, a perfectly reasonable scan. Okay. For sinus and orbit CTs, you can do a scan at 120 kV, very low dose, pitch of 0.9. You can limit the coverage to only cover the sinuses, and you can get a very, very low dose for this. Okay. So I think that point is fairly clear. The next strategy that I'll talk about is the use of iterative reconstruction. There has been a very nice talk given by Sarah on this particular topic. So all I'll tell you is these techniques do reduce noise. Okay, and I'll show you some examples of normal anatomy and some abnormal anatomy in my second talk, where when you use Acer or Sapphire or any of these iterative reconstruction, model-based iterative recon techniques, you can take out much of the dose. So for example, look at all the speckliness here and the gray-white differentiation versus in this scan where Acer has been applied. Okay. So these two are with Acer, these two are without Acer. On top we have 5 millimeter cuts. So here, this is a readable scan. I can look at the gray-white differentiation, and it looks better. Much of the noise has been taken out over here. But what is more surprising to us, to me at least, is the fact that this thing applies even for a very thin slice. So it's a 0.625 millimeter slice with filtered back projection, and this is the same slice reconstructed with Acer. Okay, I can look at the gray-white differentiation. It's almost readable for stroke. Okay, and that's a revelation. So at our site, we have reduced the MA values, and at the same time, we have upped the percent Acer that we are applying. Okay, so on these thin slices, we are nowadays applying 90% Acer. Okay. And this is an older slide again with 30% Acer. It is showing you what is the typical reduction you can expect. We went down from about 67 milligray to about 50 milligray, similarly from 60 to about 40. So for each exam, there is a reduction in the overall CTDI wall that you can get. Okay, this is the protocol that we use. Until recently, we were using a fixed MA. So we are doing a helical scan, 120 kV, 250 MA, pitch of 0.5. Slice thickness of 1.25 and an recon interval of 0.625. We have recently changed this to an auto MA, as I was proposing earlier, and rest of the protocol is pretty much the same. Okay. And this is the result that we're getting on one scanner. Okay. So we have these are the results of last 50 patients, the CTDI wall for them. Okay, earlier there was no Acer fixed tube current, and we had about 67 milligray and an effective dose of about 2.6. That's an estimate. I should emphasize that's an estimate. And once you go through all the things that I talked about today, you can bring down the CTDI wall to about 31, 32 milligray, and an effective dose of about 1.2. Okay, and these are the scans for the last 50 patients. We are averaging about 30 milligray, a little bit, pretty close to 1 millisievert. Okay, still not sub-millisievert, but pretty close to 1 millisievert. So these are the take-home points. Justify each scan. Make sure you're following the mechanics of scanning properly. Minimize MA values. Use the proper KVP value. Configure the protocol to the clinical scan. Axial versus helical. Depends on what your priorities are. You can pick either one of them, in my opinion. Avoid orbits by tilting the gantry or tilting the head. If you are using axial, do tilt the gantry. Pediatrics, you can really lower the dose, minimize variability, and you can actually nowadays perform at a dose level way below the ACR guidelines. You can probably do a scan somewhere between 1 millisievert to 2 millisievert effective estimated dose. Okay. I think with that I will stop, and I'll take any questions.
Okay, do we have any questions? So I'm kind of hearing from a couple different places that we can maybe use a higher percent of ACER in the head than in other regions. Is that something you would agree to?
I would agree with that, yeah. Because the bony anatomy is fairly clear, and in the brain what we are really looking for is the gray-white differentiation. And I'll show you some clinical examples of how using higher percent of ACER can bring those features out.
So you would probably use a higher percent ACER for the reconstructions with the soft tissue algorithm.
That's right.
And no ACER for the bony or detail
Yes,
type images. Okay, very interesting. Oh, one more question?
Really appreciate your presentation, especially somebody else joining us in that way low dose outlier group. But I think you were mostly talking about routine heads today.
That's correct.
Can you say a few words about what other protocols that you might be really, maybe even more aggressive, that are still head protocols but maybe not routine? Other kinds of things, temporal bones or facial bones or other places like that where we could really be even more aggressive than you've described.
Yeah, so anytime you're looking at bony anatomy, you can really go down. So that includes sinus CT, that includes temporal bone CT, as you mentioned, that includes facial CT scans, because we're really looking for bony anatomy in that. Anytime you're looking at repeat scans, there's a fixed question, you're following hemorrhage, okay, and that's whether it's getting bigger or smaller. You can really bring down the dose. On all our portable scanners, so we have a neurological scanner that we take to the patient for patients in neuro ICU, and the CTDI wall there is close to 40, okay, and they are deliberately set low because of that reason. Anytime you're doing a scan for shunt placement, okay, you can do a very low dose scan. Ventriculostomy catheters are visible on chest X-ray or like routine X-rays. So if you're looking at the location of the tip, you can really go down on the dose. So these will be some of the examples of where you can really push the dose limit.
Thank you very much.